Infected knee replacement, as you're going to hear later, and I'm sure you already know, presents a major problem. So there's two factors I'm going to ask you to consider. There's the patient factors and the surgeon factors. Pre-operatively, we know certain things are associated with infection, and some of those that we can treat, such as nutrition or obesity and diabetes mellitus. If the patient has it, clearly we can't remove it. And this does bring to question about patient selection. Should we be operating on the very obese? And what about people who smoke? Because we know that they are going to increase the risk of infection. And it's been shown that also you get a higher rate of infection in diabetes and hypertension, and the post-operative infection rate is higher if your BMI is greater than 35. And in the UK now, some of the commissioners are starting to insist that patients for knee replacements must have a BMI below 35. However, I think at one stage not so long ago it was suggested that people, if they had their knee replacements, they might lose weight. In fact, there's quite a good paper showing that they don't. So morbid obesity and combined with diabetes are certainly a risk. Rheumatoid arthritis carries with it a significant risk, as do previous surgical procedures, although previous arthroscopy does not. Skin conditions such as psoriasis will increase infection, and preoperative skin ulcerations obviously need treated. And one of the problems we have is those who have chronic conditions that it's very, very difficult to get the skin healed, and then if it is healed, we need to get a time of our surgery, and it's quite frequently the case that it's healed, and then by the time we arrange surgery, it's broken down again. So we can choose which patients we operate on. There's nobody we have to operate on, and so to a certain extent, it's the surgeon's choice. But once we start operating, things are also in our hands. What about gloves? Well, if you perforate them, you're much more likely to get the risk of infection. And we can look at the rates of glove perforation, and we can look at the site. And so the only thing we can do is try and buy good quality gloves that are not prone to tearing. The way we put on our gloves is important, and what gown we wear is important. And these are all things that the surgeon can choose. And we know that if you have a hood, you're much less likely to get infection than if you use simple simple hat and top. What about the operating room itself? Once again, I think this is within your control. You should not open the trays until about to use them. You don't want everybody walking around in the operating theatre, and the environment needs regular swabbing. Tourniquets haven't been given much thought in the past, but it's quite clear if you look at tourniquets, they are the source of infection, and they're very difficult to sterilise. And there's a good case now for using disposable tourniquets, or if you wish, don't use a tourniquet at all. I think the current trend is probably away from using a tourniquet for knee replacements. Don't open the trays until you need them. It may sound very sensible, but one of the problems is that someone has to check that what's in the trays is all there. If you don't open them early, you can't check them. Staples became very popular because they were quick, but they are associated with infection, and personally I don't use them. We can wash the wound out before we close it, and betadine lavage, simple and inexpensive. It probably helps, but because it's cheap and easy to do, I would recommend it. Bandaging the limb afterwards is a good way of producing pressure, stopping infection and oozing, and I would recommend it. What about after the surgery? Well, we know that these conditions are associated with increased wound infection, and the only one I'm going to draw your eye to is the urinary tract infection. It's quite reasonable not to operate on people who have a preoperative infection. And then the discussion about what sort of anaesthetics, and then if it increases the use of a catheter, urinary catheter, and urinary catheters are associated with infections. We need good nursing care. We need to teach our nurses how to manage the wounds, and I think in particular there is no need to change the wound just because a certain time frame has passed. If the wound is dry, there's no need to change it. and even if it's just a little bit moist, I suggest putting another one on top. Regular changing of a wound, every wound change is an opportunity to introduce infection. Well, what is an infection? We need to define it if we want to measure it, and it's at or near the operative site within 30 days. As I said, there's 3 major sources, and Staph aureus is probably the most common bug. The incidence of infection is probably a minor infection. I think that's probably a bit high, but it's certainly not 0. It's more frequent in total arthroplasty. And if there's a precarious blood supply, the best management is obviously to avoid any wound complications. If we get blisters, they're often associated with the adhesive on the dressings. They lead to infection and delayed healing. And the incidence of blistering is quite high in my experience. It's probably 10 to 20%, and it's often associated with trying to stretch the dressing on rather than just putting it on in a non-traction manner. And blisters come because of movement between the skin and dressings, and as I say, I think dressings have moved on. You need to have a soft dressing that doesn't stretch the skin. The best way to manage blisters is to avoid them, but if they do come, then I think we're best left alone unless there's a sign of infection. And I wouldn't give antibiotics just because they've got a blister. If you do have a wound that needs draining because it's become a hematoma or you think it might be infected, don't wait. So prevention is the best way. Sorry about that. And if you get superficial skin necrosis, it does happen occasionally, particularly with difficult knees, where the skins have been undermined. This is a real problem, and I think it needs early intervention. Immediate debridement, and often they will need a flap, and this is what you don't want to see, prosthesis exposed through the skin. When closing the wound, we want to try and get maximum blood flow, but we want to minimize the bacterial contamination and dead space. Subcuticular stitches are best, and as I said, I would avoid staples. And I think to avoid hematoma collection, drains can be used, and I think heavy bandaging. Occlusive dressings, they're better to use them. They allow the reepithelialization, and that's better than exposing the wound to the air. I think the timing of dressing change is something that seems so simple, but I would ask you, don't change it just because a certain amount of time has passed. Every time you change it, you increase the risk of wound infection. How you close the wound is important, using a layered wound. So I always use a subcuticular closure and then put a dermal bond or a glue on the joint to prevent it leaking. This is the sort of wound you're looking for. It's almost dry, and if you can get that at sort of a week, you're doing very well. So the first dressing change can be 10 days, which is when you're going to take the suture out. It's got the advantage of reducing infection, and it reduces the pain associated with it. Because they're waterproof, obviously the patient can shower. Dressings can be left in place, and as I say, because they're clear, you can also see through them. Post-operatively, physiotherapy is important. There's no point, to say, sitting in bed waiting for the knee to work. The patient's got to work hard on it. That's what the physiotherapist does. We know that physiotherapy will encourage wound healing as well as improving function. Adequate follow-up. You've got to look at the patients. There's no point discharging them day one and then ignoring them. And if you don't follow them up, you don't know how good you are. And that's where audit comes into it. We haven't necessarily measured our wound infection rates, but in England now, our personal infection rates are published, open to the public, and that, of course, is giving people cause for concern and making them give attention to all those points I've just mentioned. It's a team effort, recognise it, and hopefully infections will be very low. Thank you.
Thank you very much. Any questions from us?
Scalpels, they create more infection than suturing.
Yes, and they're painful to take out. I think subcuticular stitch is the best way to close the wound.
You prefer suturing?
I prefer a subcuticular stitch where you run it underneath the skin so the skin edges can heal directly.
electronic vacuum assisted closure?
No. Well, I haven't used it. I couldn't comment for actually closing it. Very good for infections.
I think betadine prevents healing. Whether to use betadine irrigation?
I don't think there's any evidence that betadine lavage sort of prevents healing. But
Any role for the drains in a severely obese patient?
sorry, it's very difficult to hear.
Any role for the drain?
Any? Should you use them?
The question is, any role of suction drains in obese patients?
Oh, sorry. Yes, it's very variable. There's some people now who are not using drains at all, good attention to hemostasis, putting adrenaline into the wound and heavy bandaging. Others will put wounds in, and in obese patients they will put a drain in the subcuticular layer. Personally, I think if they're very obese, I'd put a drain in the obese layer.
Thank you very much, Lawrence.
Thank you.
Just for my knowledge, would I just see a show of hands how many people in this audience use staples and how many use sutures to close their wound? For staples, I think the majority has sutures. Okay, one more thing, how many of us use autoclave tourniquets? Thanks.
Thank you very much, Lawrence.
One last question, last question, okay?
How do you prepare pre-operating this operating site? Do you want immediate saving or applying some cream?
I think the question was preoperative skin preparation. The current protocol is that they have a simple wash on the morning of the operation, and then in the operating theatre we use a chlorhexidine in spirit. Shaving, yes, I shave the wound and we do it in the operating theatre. I think if you do it the night before, you get little microabrasions which are likely to lead to infection. And I only shave the area where I'm going to make my skin incision, so like an inch wide down the front of the knee.
Thank you. I think we should now follow the next speaker.